I'll talk to you about MIS and how that has an impact on deformity surgery. So I'm not a deformity surgeon unless you consider everybody a deformity surgeon. As we know, some surgeons cause it and others treat it. But I'm not a deformity surgeon per se. In the integration between Cornell and Columbia, the spine groups, as you know, we've got a number of amazing deformity surgeons, and I just saw that Larry called in as well. Got Kai Fu. I have a number of deformity surgeons to choose from if I really have to treat a deformity case. Mike Verk does more and more MIS deformity correction. What I want to do, though, is I want to give you an overview over what I think is a rational approach, and I think what we have in terms of data that would support, for certain deformities, the application of some of the less invasive and minimal invasive surgical techniques and technologies that we have available. Now, most importantly, you have to keep in mind that MIS obviously is not a cure for everything. We want to achieve the same goals, though, as open surgeons, hopefully by causing less surgical stress, enabling early return to function, and maybe even causing better outcomes than with open traditional surgery. And I think the verdict for many pathologies is still out. I want to put in a shameless plug for this book that just came out that summarizes a lot of the things that I'll talk about. And many of you in the audience and online were co-authors. So thank you for helping with this book, really summarizing a lot of what's going on and what has been achieved in the MIS world and a lot of things that we need to achieve in the future. I had talked briefly earlier about complexity of spine surgery, and this is really degenerative and deformity related. If you look at simple complexity versus more complicated cases on the right side, you'll obviously see that with traditional surgery, that invasiveness curve goes up very quickly. So even with relatively low complexity cases, with open surgery, they can become relatively invasive in terms of blood loss, infection rates, length of surgery, and so forth. Now, the whole goal of MIS is to dampen that curve and reduce the level of invasiveness. I think what we can say, though, is at those extreme ends of that curve, I think it doesn't really matter a lot. If you do it open, if you lumbar disc herniation, or if you do it endoscopic or with a tube or even with open surgery, it's a very, very good outcome for patients with relatively low complication risk. And I think the same thing is true for complex deformity cases. Now, the question is, what can we do with MIS that's going to help us expand to the area of complex deformity while then hopefully also reducing the complication risk and improving outcomes in these patients? I think currently for MIS, the MIS benefit zone is really the middle zone. I think that's the zone of, in terms of pathology, I would say 1, 2, 3 level lumbar stenosis, 2 mild, moderate deformity cases maybe that require a 3, 4, 5 level fusion. I think those are the cases that really benefit from MIS, and the tools and the technologies are obviously endoscopy, tubular retractors, expandable cages, and so forth, lateral surgery, and I'll talk about all that. If you look at the volume, if you look at the number of cases overall, you'll see that a huge number of cases, a huge percentage of cases, especially in the degenerative world, can be partially or completely treated already with MIS. And I guess it's about maybe 75% or so of cases in the degenerative arena. Now, what are the tools and the technologies that MIS gives us that may help us with these cases? I think we've seen some data today, and we all are familiar with navigation. Some of us use robotics. And I think theoretically, this can really span the whole spectrum of spinal disease. Tubular surgery, I think, is beneficial for lumbar disc herniation, lumbar stenosis, fusion cases, obviously to a certain number of levels. And I think we've got a lot of evidence that there's a benefit. Endoscopy, as I mentioned earlier, when Christoph gave his talk, I think it's an amazing technology, but it's very limited to the left spectrum, the low complexity cases. When it comes to deformity, though, I think the biggest promise here is really lateral surgery and expandable technologies. And that's what I'll talk to you a little bit more about. Now, we all know that surgery for adult deformity is obviously superior to non-operative treatment. The results overall are excellent. However, there is a significant risk of complications. And these are just some papers that summarize some of the complications as high as 78%. That may be pretty high. But between 10 and 50% of some type of complication with open traditional deformity surgery, I think we all know that this is something that is happening, and it's frequently justified, but it is a high price to pay for patients, of course, and we're trying to address that. Now, in the book that I mentioned, there are several chapters dedicated to deformity, and what we talk about a lot is obviously lateral surgery. And I think lateral surgery, whether it's lateral or prone lateral, I think allows us to address a lot of the deformities. Originally, it was really more described for indirect decompression. It's really one of the treatment technique principles of MIS. You don't always have to perform a direct decompression. In many cases, an indirect decompression will treat the patient, treat the pathology, stabilize the spine, and maybe even treat the deformity, so you can achieve several goals with one surgical approach. And that's obviously the best of all worlds. Now, the idea between indirect decompression is pretty well established for certain amounts of lumbar stenosis, for foraminal narrowing. It doesn't work that well for lateral recess stenosis, so you have to keep that in mind. And then obviously over the last years, what really became of interest was lateral surgery for deformity correction. And this is a case we did a number of years ago, adjacent segment disease, with a hyperlordotic cage and ALL release. So you can get really beautiful results with, and now also with expandable cages. There are expandable cages, cage technology coming out for TLIF surgery, for ALIF surgery, for lateral surgery, and then also obviously the hyperlordotic cages. And the question is, if you use these technologies with less invasive approaches, are you going to be able to cut down on some of the complications of open surgery? Now, Juan Uribe, Momonemi, several others, you see it here, have published results using hyperlordotic cages with and without ALL release. But especially with ALL release, you can achieve very significant amounts of lumbar lordosis, and there are different types of surgical techniques that can allow you to maximize that by removing the facet joint, or doing various types of open procedure or mixed open procedures in the back, or even MIS. You can maximize the amount of lordosis restoration that you can achieve with expandable technology and with hyperlordotic cages. Now, the risks are potentially significant, though. You have to obviously look at the vascular anatomy. You have to look at the bony anatomy. So I think that all these technologies come with a significant risk to patients, and I think we cannot underestimate that. Another technique principle that really has gained attraction in the MIS world is percutaneous pedicle screws with navigation or with robotic surgery. And now there are various companies out there that offer pedicle screws that can be inserted without the need of K-wires and multiple tools that are being inserted. We use, as I mentioned before, we use 3D freehand navigation primarily, but these can also be used with robotic surgery. And the beauty of these pedicle screws is that you just navigate one instrument. They have an integrated K-wire that prevents the skiving and that allows the penetration of the pedicle very elegantly. And then you can insert the pedicle screw, and it reduces the number of steps if you do open surgery, MIS surgery, or if you use navigation. And we published our early experience with these single-step pedicle screws a number of years ago, and these are the screws that all of us really in our group at the Cornell campus now pretty much use for MIS surgery. We still do a lot of lateral surgery for cases that require instrumented fusion. Some of us have started doing prone surgery as well. I like the lateral approach because it also gives you then the ability to perform an ALIF in a single-stage procedure. We then put in the pedicle screws with navigation. And I was very interested in the success or the failure rate of indirect decompression. And we published a paper a number of years ago that quoted at an about 10% failure rate of indirect decompression. So now we started using tubular retractors in addition to putting in the screws from the side. So I bring in the microscope if I think that patient also needs a direct decompression. And through a lateral position with a tubular retractor, you can very elegantly and very quickly, actually, it's almost easier than doing in prone, you can do a direct decompression in addition to the indirect decompression that you did from the front, from the side. So we have all these techniques and tools available for MIS deformity correction, or that could potentially help us. How do we make the decision? And obviously, this paper here was really fundamental. Chris Sheffer just talked about the ISSG, and this is a paper that came out of the ISSG. Kai Fu, who's one of my partners, was very involved in this as well. And there was a precursor paper a number of years ago, and then the follow-up paper that really describes that the majority of deformity cases, unless it is a fused or rigid spine, but the majority of deformity cases can be addressed at least partially with MIS technology. And really what has changed over the last years then, that really also changed this algorithm, is the introduction of ACR, so anterior column reduction with MIS technology, with lateral approaches primarily, expandable cage technology, navigation, robotic surgery. All these tools and techniques that are part of the MIS toolbox have allowed surgeons then to really expand into the deformity world. And I think the majority of these cases now can be at least partially addressed with MIS. And these are some of the examples from this paper. Class 1 to class 4, class 1, class 2, and class 3 are mild to moderate deformity cases. This patient had a multi-level ALIF, and then MIS pedicle screw instrumentation and iliac screws. And then this patient had an ACR done, and then this patient had an open deformity correction because of the significance of the curve and the rigid curve that this patient presented with. So how do you make a decision then? And how do you make a decision then as a surgeon who wants to treat a deformity patient in terms of what type of MIS technology to use? And again, the ISSG really published a beautiful paper on that, where they summarized the various cases that had been done with MIS approaches. And in this study, they looked at circumferential fusion cases that underwent either a straight lateral approach without ALL release, an ACR, so that's a lateral approach with ALL release, MIS TLIF as part of the fusion construct, or an ALIF procedure. And I just want to show you the conclusion, which is really the algorithm. So that's the MI interbody selection algorithm, which is totally rational. I think it makes a lot of sense, and I think it takes a lot of the mystery out of the decision-making process. So obviously, if you have if you need to treat L1 to L4, you have a multitude of options. You can do a straight lateral approach without ALL release. You can do an ACR where you release the ALL and then maybe use an expandable or a hyperlordotic cage. All of us agree that MIS TLIF is a great operation for direct decompression, and it's a great operation to stabilize, to fuse the spine very successfully at 1 or 2 levels, but it's not a great operation to restore height or lordosis. And the algorithm fully acknowledges that, of course. At L4, L5, you have the most options. And then obviously at L5 is when you have the option of choosing an ALIF or a TLIF. So in terms of outcomes, the outcomes when you look at mild or moderate deformity overall show that with MIS technologies and adjunct, sometimes to open surgery, you can achieve very favorable outcomes. I think the verdict, whether one is better or the other, I think is certainly out, and is certainly lacking still. But I think that for the mild and moderate deformity cases, you can take advantage of some of the MIS technologies, especially when it comes to lower blood loss, shorter times in the hospital, lower infection rates. And obviously, this needs to be expanded to more significant deformities, and I'm sure that that's going to happen sooner or later. In conclusion, MIS is effective in appropriately selected patients. The tools that are available are the expandable technologies, the hyperlordotic cages, navigation, percutaneous pedicle screw systems with robotic or freehand navigation. And I think these algorithms that I mentioned from the spine study group are really helpful for surgeons to make these decisions. I think I'm at the end of my presentation. Again, I think this is kind of a summary of where those MIS tools and technologies fall into place in the spectrum of spectrum of spine surgery. So thank you very much for having me.
Great stuff, Roger. Thank you very much. Please accept our applause again, virtually. You're an authority in this subject, and your clarity of questions and countermeasures and didactic excellence are truly laudable and important. Let me share with you an observation that I've seen a lot, and in fact, I have a patient right now in the hospital with this, and that is MIS is so tempting to basically get patients into the outpatient perspective, and a true major deformity surgery is still not amenable to that. So what I'm seeing a lot is that patients kind of get shish kebab surgery. One level here, one level there. The telltale signs usually have 4 different cage constructs in their spine, starting from the L5S1 junction, and then in another outpatient stay, there's another level added, and then another one, and there's a standalone lateral cage, and at some point in time, they give up then. It's usually at L2 or L1, and then the spine collapses, and then a major redo is necessary. I'm not sure if this is a Washington or Pacific Northwest phenomenon, or if this is just too much of a temptation for some surgeons to not address the underlying major pathology by kind of doing these little bit-by-bit surgeries. Your thoughts?
Jens, I couldn't agree more, and I think the problem is really the indication. I think if you have to look at those patients initially, and you have to figure out, what is the pathology, what's causing this patient to show up. And then you have to make a decision. I think if it's a true deformity case, then I think as MIS surgeons, we're certainly guilty of bending the rules and sometimes doing an operation because we think we can do it and disregarding some of the principles that should have been kept in mind. I think once you make a decision that this is really a deformity problem and this patient needs a deformity correction operation, I think you're shifting. You really got to find out, who's the best surgeon then to do that operation? That may be somebody who does only open surgery. I don't have any problems with that. But somebody needs to understand the pathology of deformity and address it appropriately. The worst thing that we can do as MIS surgeons is to kind of downplay a diagnosis and then treat it partially. And I think a lot of what you're seeing there and what we see here is just surgeons doing certain types of procedures because they can do it now. And that's my problem with endoscopic surgery. Now everybody's going to start putting in cages in patients that otherwise probably never end up needing a fusion. But now because everybody can put in a cage through a tube in the outpatient center, even pain management doctors, that's going to be a big problem. But I think it's a learning curve. I think we're addressing that with meetings such as yours here. And but at the end of the day, it's a problem with the initial diagnosis and the initial surgical plan. I think that's the problem.
Great answer, and I appreciate your honesty. The great Dr. Lenke is here.